Oh, I'm gonna go ahead. Meeting of the Seneca Healthcare District Board. We have Sherry here, Shelley is here, Rich is joining us online, and Ken wasn't able to join us today. So let's go ahead and rise for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, indivisible, with liberty and justice. Thank you all. That brings us to item number 2, additions, modifications, deletions from the agenda. Board members, anything else? Through the agenda. We will approve this. Thank you. Do I have a second? Second. Thank you. All in favor? Sherry? Aye. Shelley? Aye. Rich?
Aye.
And I'll vote aye. That moves us into public comment period. We did not receive any public comment in advance of our meeting. And here.
Yeah. Okay, I know you're trying to improve the image of the hospital, and I've heard a lot of positive, but last night at bingo, I heard something, and I don't know how much that was after you. But we were talking, I told Jim that I voted for the hospital because of the health path, which makes it so much nicer than the other bit. And he said, well, I told my grandson that we're either the EMT or, well, one of those are the ambulance, I don't know, but he said, I told my grandson, what happens, never taking this Seneca. That's a very negative. And I don't know if it's that age group from things that happened before.
Yeah, it's very possible. Yeah, very, very possible. There's still some remnants of what we consider to be old Seneca. And if that person would like to talk to us, it all. Thank you.
There. But also, it's late because he said, they changed the name of city government to that. I said, well, we don't have a newspaper, I don't do computers, she does it. She could go on and find out.
So we didn't change the name of Seneca. Seneca is going to remain Seneca. The new hospital is going to be the Lake Elminor Community Hospital. Yes. Yeah. Perfect. We would love to welcome you into the Seneca family if you decide to leave Westwood Clinic. That was a while back, yeah. Oh yeah, a long time ago. Yeah. Well, we have a whole bunch of new providers, so if you find yourself without one, come on over, we'll take good care of you. Oh, you come from Westwood? We'll send an Uber. Yeah.
We're still in the district, but we already have a Lake Elminor clinic, and our hospital will be the Lake Elminor community.
Well, like I said, we're just concerned, getting ready for starting this with dessert. Going to the meeting, and so she said, well, when did they change the name?
Yeah.
So there's no name change, then still will have a name.
A new name.
And we'll push more about to give out it over the next several years, especially as we get closer to.
Oh, I cannot remember who the CEO, the time, they could remember, maybe. But the one gal that applies for the CEO, she came to the board, came up with this thing where the Seneca had the hands where the wheel open hands. Do you remember that one, Sherry? Do you remember who was the CEO? I think it might have been
Bernie.
I like that myself.
Well, thank you, Shirley. Appreciate your feedback.
Thank you, Shirley.
Any other public comments?
There was the last one, we had a public comment about, but,
Yes, yes.
so Judy, you
So
want
Julie, this is the last work meeting, but I really have a question about the blood that we.
I'm just curious, I don't think you have to even call, so I just wondered, they charge you when you want to, they like, some hospital charges people, Judy did it for them.
It costs us $300 per month.
So what do they keep on calling?
So thank you. And so just a little more for information. The blood is only good for 2 days. When it's collected. So what we do in the blood bank is every 3 weeks or so, we actually rotate it. It goes back to Reno where they're using a lot more blood. And we just don't go through blood bank, we leave it on. Just results, just kind of wonder if it really important. Yeah. Period. Yeah, and the pulse is going up in 2025. That's everything, so it'll cost us a little bit more next year, so they'll be calling you more.
Yeah, well, I took blood the 9th of January, because I needed to do it when they had the blood bank here, the pending, or down in Chico, or in Reno at the County Spring, or down at the kids in Arusa, you know. It depends, but,
Keep giving.
Thank you.
I'm just curious.
That's what it costs us.
Yeah, thank you for closing the loop. I appreciate that.
Yeah.
And that it's good information that I didn't know either, so thank
Yeah.
you. No idea. All right, so let's move on to item number 5, approval of the November 19, 2024 special board meeting minutes. Do I have a motion or any comments, clarifications?
A motion to approve.
Thank you. Do I have a second? Sure. Thank you. All in favor? Sherry?
Aye.
Shelley? Rich?
Aye.
And I'll vote aye. That moves on to our staff reports. Sean?
So I have a very short report, and verbal, so I apologize, I'm gonna start getting mine back into written form, so it's in here. Just some heads up, from some of our advocacy groups that, with everything that's been going on politically, we've been forewarned more or less that the next legislative session is going to be, labor is gonna become very, very aggressive in California. So organized labor, is really gonna be, in Sacramento a lot, gonna be trying to push through some serious initiatives to try to shore up what they believe is going to be a wall. I had to say that, a labor wall and locking in some labor contracts and getting some more labor activity in the state of California. It's already very, very controlling of the legislature at this point, but it is going to be playing, they're really gearing up to have a big push.
Talking about
And-
healthcare specifically?
Yes, a lot of
We
healthcare,
they just passed the
just,
minimum wage rules that are.
they're just gonna get very aggressive about a lot of things, it's minimum, one of them that I heard was minimum expectation on negotiations. In other words, they put a rate in there instead of just a cost of living, just a COLA. I heard that it's minimum 5% is what they're pushing for year over year as a base, which I don't know how anyone's gonna do that. But this is just be prepared for that. There's gonna be a lot of legislation coming down. Be aware of that. Winter break, just to let you know on the construction, we're waiting to see what happens. They're gonna try to, and Donna can probably add to this, but they're taking a look at the weather to see if we can get enough melt out there to finish up covering the fire water that was inspected and try to bring in I don't think they're gonna be able to bring it in, but the filter, the 3,000 cubic yards of dirt they wanna bring in to start leveling the rest of the site. Because once again, it wasn't an equal site, wasn't considered an equal site. So they're gonna try to do that. I haven't been in a meeting where it says they're gonna commit to it. They're just looking at the weather and figuring it out. Other than that, it sounds like we're approaching winter break and we'll start tapering against those weather days. So that's really all I have there. Other than that, I just trying to catch up on 400 email today. I was at Chicago. To take a look at the MRI and the coach for the 5 hospital consortium. Really good conversations, and I think that the price point's lower than what I expected it to be. I expect something more formalized next week from the vendors. Around that, I was able to look at some of the equipment that we purchased, you know, hands-on for the new facility, pretty exciting stuff. So, for instance, the CT that we're gonna be getting over there, they've done all these software upgrades, so software packages, including an AI package that's been FDA approved for lung nodules and stuff like that. So really interesting technology that's coming out as part of, and we'll get it because we have kind of we get the latest and greatest when we deliver. Really interesting stuff from that technology. So it was a good show, other than everybody was sick. The whole entire Chicago was all sick. Chicago, I don't know what's going on there, but it's coming west. So
Was
that's
the
it.
meeting,
That's really all.
was the meeting well attended, Sean?
You know, it was smaller than I'd seen in a long time, but all the players were there, Rich. They just had smaller booths. I think the economy's hitting everybody pretty hard, so. But that was it. Other than that, I'll take questions, and my next report will be much more comprehensive.
Questions? No. Rich, any other questions?
No, no. I'm glad you went, and I'm glad you're coming back with information that'll help us with our imaging equipment in the future.
Definitely.
Right.
Yeah,
Thank you.
okay.
All right, Judy, you're up.
Okay, so for my public health update, we are now in our mandatory mask period for flu season, so anyone who did not receive their flu vaccine, and is patient facing is required to wear a surgical mask until probably April 30th. Usually is when the flu season is being over. In laboratory, we are working on a new respiratory panel, something that, our doctors have been wanting to see for some time. Currently, our respiratory panel covers 22 different respiratory pathogens. But usually they only want to see 3 to 5 of those, but we have to do a partial. If we run the 22, we have to charge for 22. So the FDA just finally approved a 5-panel respiratory panel for influenza A, RSV, and the other 2 that we're usually looking for. And so James is working on getting that up and going and interface to the center. So, and since the FDA approved it, now we can charge because CMS will approve an FDA approved panel. So it just feels better because we don't really need to do 22. We want the 5. And so now we can finally do the 5 and get reimbursed for the cost of running.
And we can do that with our existing equipment.
He's the new cartridge,
It's a different cartridge.
but we got the equipment down.
Yeah. Let's see, I don't have any EMS updates as far as where we are with the Peninsula Fire annexation, but I know they're keeping their website pretty up to date. They have a page just specifically addressing the annexation and where they're at in that. Let's see, nursing and other workforce concerns. We are using one travel registered nurse on the acute care floor right now. Her contract at the end of the year. And knock on wood, we will have all permanent staff in the ER and on the acute care floor. I've been there 3
He's
years.
gonna dance.
Yeah, it's really exciting. And we've really picked up some really great talent. Yeah, and so we're excited.
Did any of them come from Enloe? I'm just curious.
And one's on the way, we think, but yeah, so not recently, none of them came from Enloe, but some of them have come from people who are already permanent employees who are boasting about how wonderful it is to work at Seneca, and they're bringing their friends here. Yeah. We are going to be posting for a part-time weekend house supervisor, and we do have a registered nurse at Enloe who I've worked with for a very long time, who's very interested in that position. And I think that will provide a great deal of relief to our director of nursing, and as well as the ER and acute care floor to have that extra RN. That is a position that has been open for years on. So we're excited. Yeah. We hired 2 per diem dietary aides recently, and they're doing really, really well in the kitchen.
And laboratory, they had their last contract person, CLS, the contract ended in November, so we're using all permanent staff for clinical lab scientists. We are still relying on registry staff for phlebotomy. It's for a little bit longer. Regulatory activity, we had, the full certification and relicensing survey last month. We submitted our plan of correction. It was related to serving, resident Russell Sprout, and someone who do not like this. And then we had one other finding related to, quality control fluid that wasn't labeled. So it wasn't a long plan of correction that you received yesterday that they have accepted it, so we're done with that.
Great job with the survey.
Yeah, they did so great, they really did a wonderful job. And then, for the Seneca Auxiliary, we are currently, requesting managers to put in their wish list items. The auxiliary has had their final meeting this year, but when they reconvene in March, at that meeting, they will be looking at the wish list and, making their approval during the March meeting.
Do we invite your board members to our Christmas party? Okay, good.
Yeah, they got their invitations this week.
Great.
And then the other thing that I know, we had this discussion earlier today. One thing that we are, a transitional item that is going to be tricky for us logistically, moving into the new hospital that has been identified through some other meetings that we've had in the last couple of weeks. Is our laboratory is almost all existing equipment that is going into the new facility, whereas almost every other department would be net new equipment. So it won't really impact our old hospital operations, but for the lab, we're going to have some potential impacts if we don't come up with a short-term solution, while we're waiting for our certificate of occupancy. So one thing we were talking about earlier today was whether or not we need to bring in a mobile lab, whether we could potentially lease, exact equipment like we have now. So that we can move the existing equipment into the new space while we wait for our CDPH sign off. So that is something that, we're looking at right now, because I think we need to start planning for this sooner rather than later. So we'll keep you updated on what we come up with.
Can you use runners, kind of like you do in downtime, Runners.
Well, I don't know that you can operate the laboratory in the new space without a certificate of occupancy. So we'll have to have the dual laboratory operation for some time. Because what brought it up actually was at the electrical meeting, we were talking about how a lot of the lab equipment, including the blood bank, requires monitoring, temperature monitoring, and it has to go somewhere. And all of those alarms will go to the emergency room where we always have someone there. And then we realized, well, how are we gonna test the alarms?
Yeah.
If the equipment isn't in the hospital? And so, so we're gonna figure it out.
Yeah.
And we'll get back to you with what our solution is going to be. Linda and I will be talking with our local office at CDPH, to see how maybe they've overcome this with other hospitals in the region. And we'll probably talk to MODOC and see, if they were net new in their lab, or did they have a we'll get back to you. Any questions?
That you caught that
Yeah.
now.
Yeah.
Yes, yeah.
Mobile labs, are they pretty common or?
I
hard to come by?
Sean mentioned that he's had some experience with them.
When we moved, the hospital I worked in, and same thing, we're taking all of our lab equipment, it's fairly new, and we were able to bring in a mobile lab that had all of the analyzers and everything in there. And they were able to do the work. We made a relationship also with our reference lab to do a few more things. But we were able to do a lot of the stats and the things that really matter to our patients. So we'll have to take a look into it, see what's available out there. The equipment or the movers which we're gonna get, the company that is in the budget will have the logistics of moving will also have several ideas on,
Hmm.
they do this for a living, they'll have several ideas on how to move that stuff over and keep operations pushing forward,
Right.
so.
Otherwise, there's no real critical path equipment outside of the law that I can think of, because we will be moving some of the beds and tables and things like that. Or that would be really easy. We've done that in our moves, you know, down the valley, but it's this critical path stuff where we cannot be without lab. I mean, we know how it was even when we lost one test last month and we weren't able to run components for several days, was highly impossible for our organization, so.
What about radiology, like the
So,
ultrasound and all that?
Net new,
Well, we just got a new ultrasound.
Yeah.
that'll wheel over, it's on wheels, but CT, the X-ray, everything that is required to be locked in and seismically anchored is all net new, so it'll be sitting over there, it'll have gone through a physicist report, it'll have quality control QA done on it, it'll be ready to go day one.
Okay.
And how long do we say we thought it would take to move the lab equipment if we were just moving it straight over and not installing
Not
anything
sure.
new?
Well,
What do you think, a week?
no, well, you have to let the analyzers sit, so they have to get certified in their location, go through the thing, so. That can be a week to 2 weeks process, so,
And
one
that
of the.
happens before you get your certificate.
Yeah, so one of the things we can do is lease equipment over here, move our equipment ahead of time into the new space, get it certified, all of that, still running the lab. The cancer center was that kind of a,
Right.
you know,
We were just cautioned that, unless we're using exact equipment,
correct,
it becomes a new HCI project.
Correct.
yeah.
And so, we just need more information about what we
And
have.
does that include whatever we are using in our existing, for our existing, has to be the exact same equipment as well?
That's what James told us.
Yes.
Part of the benefit of the mobile lab is that it is CDPH. It's just basically, they have their own CLIA
Yeah.
license, they come in, it gets power, and
So that would be an issue.
Yeah.
it's not an HCI thing, because it's literally here temporarily to assist us in our move. And CDPH usually just approves
I
it.
think they'll be, I mean, we have a really wonderful relationship with our CDPH office, so I think they'll be willing to walk us through
Yeah, they
that.
probably have suggestions as well. Yeah.
But we'll see what they've done, at other facilities.
Nice thing is, we're already 2 years ahead of that.
Yeah.
Logistics move, and we're thinking about that, so
Yeah, well,
Exciting.
integration.
integration will be the tricky part.
Yes.
It's not the exact same.
No, I already told Sean that you can have vacation anytime.
Take all your vacation now. You've moved a hospital, you know how crazy it is.
Yeah, and then they cut out for infrastructure cabling. So, yeah, and keep the hospital running.
Well, I think you do.
Thank you.
All right, Brady, you're up.
Thank you. So in the monthly report, it's similar, but in the back, Candace and myself and others looked at a couple other different reports and expanded on the 2 reports for this time. And as a reminder, we're gonna kind of deliver some different reports. We're gonna talk about them. And like, wanna see this quarterly, wanna see this yearly, that kind of stuff. So before we get to that, a couple things in the clinic, as a reminder, Stephanie White started this week, so, that is exciting. We are seeing, the start of respiratory coming in, so wash your hands. Linda's, category, we did, so thank you for the backup batteries, we did, put those in, so the generator is, up to. Ready to go. Yeah, ready to go if we need that. We did go through that atmospheric river, everything was fine, but it's up very quickly. Volumes, radiology volumes are still holding.
And I like the ultrasound number.
Yeah, and growing.
Yeah.
Obviously, our MRI number is gonna stay the same until we find a solution for that, which we are getting closer to. And then, the two reports, so, the first report is a qualitative report, meaning the area that these word clouds come from is an open, text. So you could put the dog ran fast and it would
Right.
be in there. So with that, and word clouds are supposed to be kind of fun and, you know, that kind of stuff. So you can see and where you picked this up, which Candace, if she's not willing, but it's medication refills. So one with an S, one without an S. But you can see if you combine those two, that was for that period of time. What I did, just to give you kind of a foundational base on this report, is we broke up the time frames. And so when you go to the bottom left and you see January through March, so we picked up partnership. So you can see establishing care was big, so that makes sense for what we went through. Then you go through April through June, you know, you look for establishing care smaller. And then it's coming back July through September. But when you put them all together, January through October, obviously medication refill is one of the most largest visits, and establish a care is still holding its own. So when I looked at the new patients per month, we're bringing on anywhere from probably 20 to 40 per month. And partnership gives us a list each month, and we have to call them and establish them and all that. That can be anywhere from 10 to 12 patients per list that we've seen so far. Now, not all of those may establish with us, but they are in our area. And so that's how that goes. So on this one, we will report this one because, you know, a month, we're not gonna see a difference. But we'll report this one maybe on a quarterly basis, so you can kind of see, so we can get the boxes of January through March through this year, this fiscal year, and just kind of see what we think at the end of it. Do we want to keep looking at that or not? It's a qualitative report, so it's a little squishier, versus the next one. So any questions on this one? This one is just the top 20 appointment types.
I like it personally. I do too.
Mhm.
Okay,
Yeah, I think it helps give a good picture of why people are coming in.
Or like a quarter.
yeah.
Yeah.
Really love seeing
And
that,
I think
establishing
that's
care,
Mhm.
establishing care, keep that one.
We'll kind of know the time frame when people tend to be doing different activities.
Now, what we can do to clean this up is internally, we can, because I'm sure this is a global change if I ask to do this. But internally, we can give for the reasons a visit. Usually you're talking to the patient and you're saying, hey, you know, med refill, fine, okay, that's an easy one, don't put an S on it or put an S on it, it's. But when it comes to other things, sometimes I'm not feeling well or I'm established, we can have internally have a list of, you know, 10 reasons, and so we pick one of the 10. And then maybe an other section, so we can fine tune this a little bit, and Jerry brought that up, so that's the way I was thinking about, still qualitative, but we can, you know, kind of tighten it up a little bit, so that's a thought. So we'll do this one quarterly, and then just see how the word cloud turns out. The next one is kind of referrals. So this is one of our projects. So we have phones, referrals, all of those projects going. So we wanted to kind of show this one. We only have 2 specialties. So we're a primary care practice that has 2 specialties. So when you call leakage in healthcare, it's usually you're losing, you know, that they're not within your network. Well, we only have orthopedics and general surgery. So the leakage is actually referrals out to, you know, to, derm, all the other stuff. So it's not necessarily a bad thing, because we don't have all those services for that. But this kind of gives you, kind of the months, the leakage, and how many referrals we do. For one clinic, we do a lot of referrals. And so that's, it's kind of interesting on how many.
It'd be
referrals.
interesting later on, at a later point, to be able to know how many of the leakage referrals was for cardiac. Was for
Good point.
neuro, was for
Okay,
GI, was for,
Well-
mammo,
What
for,
specialties we need.
right.
yeah, and
right.
we can do that, yeah.
And we certainly hope to see less red as we start to build into the new facility where cardiology, podiatry, dermatology, we would like to see less red and do more blue internal.
Yeah,
That's just a matter of recruiting our specialty providers
But
to do work up here.
To Shelley's point, that would help us
Break it down.
get to
Yeah.
where should we be focusing on bringing some of
Definitely.
the.
yeah,
for different
and we
areas.
can do that,
Mhm.
it can spin down to that. So any other questions or ideas on that one?
Let's see that.
Okay. So then, to get a little more granular in the referrals, so we put the definition of what does not started stand for, because Cerner has their own words and they mean different things, and we kind of found out internally. So these are the definitions, and Candace found all this. These are the definitions, and these are the line items of how many referrals are within those categories. And so obviously the from this, from an operational viewpoint, something that's not started, my question is, well, is it 1 day? Is it 2 days? Is the time on that?
Yeah.
And then prep for send, and we have all these analytics to get deeper into it, but these are the things. Prep for send, that means you're preparing the package, the last clinic note, all of that stuff for the referral. And then you're sending out, that could mean, 2 things. You've sent it through Cerner, which means through the system to Cerner's fax, it goes to the specialist. That means it's sent, not that they have received it.
Right.
And so that's a whole other thing, that you
Right.
gotta call them and making sure they've
Yeah.
actually received it, which you can't track that in here, that's just an internal function. And then pending acceptance, like, yes, we've received it, we're reviewing it, and then actually accepted, on hold, rejected, and all of those things. So we can get more granular into this, so if there's some things as you're thinking about, cause there's a lot of analytics behind this one. But that just gives you kind of a flavor of that and where the stages are, on that one.
And thank you for the definitions, because when I was looking at it, I said, well, if it's completed, does that mean they've already also been scheduled? Does that mean, yeah, so the definition,
Yeah,
I found very helpful.
well, we had the same thing, was what does not started mean for you? And we had this internal discussion, cause everybody thought it was something different.
Right. So what about, so patients referred out,
Yeah,
and then they're seen.
yeah,
What about circling back to the PCP, to the
so,
referring physician?
yeah,
and
so-
Documentation.
so
That's when I did
So it's not started, I prep for send it, I send it out, I call them, did you receive this? Yes, we received it, we'll give it a doctor, will give you a call and give the patient a call if we're accepting it.
Mhm.
We call back if we don't hear, and there's messaging in below each referral on, if you touch it, you type in what you've done.
Mhm.
So then it's like, yes, we've received it, yes, we're accepting it,
Mhm.
their appointment is on such and such.
Mhm.
Then they have their appointment, then we get a note back for the PCP. And
Right.
then it's put back into the system, so the next time, he or she sees that patient, the referral they sent out, they see what the plan is and what their part of the care plan is. So that's the closing the loop of the referral.
Nice.
Does Cerner have, so if we're told a patient has a referral appointment scheduled for a certain date, do we put that in Cerner? Is there
Yeah.
a particular that can?
Yep, yep.
Okay,
yeah, there's a drop down and the date and everything, so you can, see that.
The little prompt that
Yeah.
get the
Now,
documentation. if it's not
Yes,
on the-
that's if they're built in our library of referrals. Meaning the doctor's built into the system. If it's somebody that's not built into the system and we print everything out and fax it to a provider that's not in the system, some of those features you can't, but in the free text, you can say, like, I faxed it directly to this number, to Dr. So-and-so and stuff like that, so.
Meanwhile, they're also sending that information over to IT to get them added.
Yes, to add to it, yeah, and that's a whole project where, because that library
Yeah.
either grows or doesn't. So that's part of the project we're working on, is making sure that stuff is dialed. But also understanding the power of Cerner and making sure we're understanding it and using it correctly. So that's kind of.
So do you have a team that's dedicated to the specific thing with the referrals?
So at one point, we were centralized with one person and, there's some medical leaves and stuff, so we decided to do a decentralized model, meaning whoever the provider is, the MA or LVN working with that provider owns those referrals. Because they're, in contact with those patients, rescheduling them, making sure, that they've done everything before they have that appointment. So that was a big, undertaking for the clinic staff, but I think that was the first move. And I think we've got it, working. It's still, we do a lot of referrals, so it is.
Clearly.
Yes, so you gotta keep up on that. Now, on the staffing, so we're down one LVN, and so we're interviewing and stuff like that. So when our model of staffing, then we gotta hustle more to keep up with the volume, so that's an ongoing thing. So that's referrals. Now, Rich, this one's for you.
Thank you.
So this is Candace. I think Sean and I have talked probably, 6 months ago. And you brought up a zip code analysis. And so there's a lot of data, even more granular than this, but we thought we'd start with this that is a little higher level. Steve had some information that we kind of brought into this, so it's a more comprehensive of our service area. So in this analysis, we're gonna go with the primary and secondary service area. We did the zip codes and the names of the zip codes, so you kind of have that picture. We called out the PSA and the secondary service area and the outside and the numbers between a time frame. We can get down, which we probably wouldn't want to show that in this form, but we can get down to male, female, age, you can get very granular, but I think for a good start would be this gives a high level view of the service area, the volume, the time frame. And, now Sean mentioned to me that LAFCO is looking at the service area, to our service areas to see if a redesign, is warranted. So this map may change, which may encompass more population within a service area. So that's that.
Can we, excuse me. Good thing I'm not there. I've got a bad cold. Can we break down the zip code into?
Yes, we can do very detailed, but I don't know. I know we had discussions about how detailed we wanted to get or not. So
Well,
that's,
for example, 96137. As you know, the peninsula is 96137.
correct,
And it's not Westwood, so there's a difference. So,
correct.
yeah, and
Okay, I can probably split that out. I mean, we've spun it different ways. You can get age group, you can get really detailed,
Can
so.
you do,
But are you able
can
to
you do communities?
Can you even split out Westwood from the Peninsula and Hamilton Branch because they're all the same zip code? That would be more of a street level stuff, which I don't know if we can do. I mean,
Yeah.
probably.
It gets, we rolled this up higher to start with because it can get pretty granular.
Yeah, because, I mean, if we know, well, obviously we know Chester, but if we knew, you know, the Peninsula, Hamilton Branch, West Shore, you know, the communities that might be helpful.
Well,
And also time of year, because, you know, during the summer months, I would suspect that the primary and outside of our primary and secondary may be quite different in the summer months.
yeah, we could,
It should be,
well, we could do different snapshots in the time period, which would capture that.
yeah.
We did talk about if we got too granular.
That would speak to the building.
Yeah, where would that be in open section or closed section, you know, cause it gets pretty detailed. So those are things that I started out high and we can go down deeper. And Rich, I will see if I can tweak the 96137 to split that out a little bit.
Yeah, Plumas County versus Lassen County, if it's possible.
You know,
Yeah,
that
because that will
Yeah,
tell
the
us
county
if we're getting
dividing line would be a good.
partnership.
if we can,
Okay.
if there's a data point that would specify that, that'd be great. Brady, I got a question on the outside of the PSA and SSA. So these are generally people that are visiting us that are, well, visiting us.
Yeah.
Is there a way I know there's a way, if you take those 592, not like it matters to me very much, but we can find out where they're from.
Oh, yeah. No, I just.
And this will help with our marketing.
Yeah.
Let's just say that there's a hub that's coming from Chico.
Yeah,
You know, let's understand where those people are coming in from.
yeah, no, definitely,
And is this based on zip code, billing zip code?
yeah, this is,
Insurance, usually, right?
yeah,
Okay.
where in our database of population, what zip code they have.
Okay,
Yeah.
not their home, because someone who has a second home here might put that in.
No, it's
It's
out
actually
of,
their billing zip code.
yeah, it's out of our
So
system
some of those
where they're
are,
coming from.
some are part-time residents here.
Yeah, if they
That would
come,
be interesting.
well, if they come here,
They give their
but
mail
never
address.
visit us,
Right,
then we won't see that, but this is coming out of our,
So when we register them now, if they come here and they're say from Orange County, when we register them, when we get their address in there, it's the Orange County address. That's where they're.
their driver's license.
It's off their driver's license.
Oh,
It's their
okay.
billing. It's where they're gonna get their bill.
Yeah,
And
So-
they won't do it here.
for an example, LACC,
yeah,
probably more than half of
We
the residents in there are secondary or third residences. So when they come here in the summer and then they are ill and come to our facility, they would be registering under their home address.
Correct.
where do they get their mail?
And that would give us, that's on the outside of our PSA and SSA. That's where we
Yeah.
can actually start to, we'll know where
Look
they're
where they're
coming in
coming
from. Like I say, if we've got a big Reno presence or there's, let's just say a lot of the 592 is Chico, Butte
Mhm.
County, then we, you know, our focused attention should be maybe a little bit of marketing down there, awareness. It'd just be good to know where people are coming in from,
Sure.
right? So,
So we'll make some adjustments, but I would like to give a shout out to Steve and Candace because there's a lot of data behind this to roll this up into a presentable, document, but we'll make some tweaks to this. And then would this be good to see on a quarterly basis? So you might be able to capture winter, summer, spring,
I think
fall,
that would be cool.
so we can kind of see the fluctuations.
Yep.
Okay.
Is that good to you, Rich?
Yep, great. Good report.
And then, the last page are just the ongoing projects, that we're working on. Doing a lot of colonoscopy outreach. And then, just kind of our practitioners with Stephanie White starting, so we're pretty, staffed from providers. So, which is good. And any other questions on the report?
Board members, any other questions for Bill?
That's great,
Yeah,
thank you.
and then we'll probably throw a different one in, the next board meeting and just,
We'd love to see him.
yeah.
Good.
Yes.
Okay, thank you.
Thank you, Brady.
Wait, it's Brian, you're up now.
So the good news is you're seeing me here, as last night Sarah did a major upgrade, so. Go
And you
bump
get invited by your birthday, right?
No, if I'm sitting here, that means that went relatively well. As far as we know, operational wise, they went. We'll see what's happening on the back end as these accounts go through. Bree Denny is back. She spent her day with Heather Smith today, trying to help her along and find workflow resolutions for her documentation challenges. So that's another good sign. We are finishing up the printer install, so my focus right now, after being here a little over a year or so, surviving a winter and going into another one, is looking at our operational expenses and what our contracts are and what they really should be for where we are right now. So we adjusted the internet contract, got off a bad contract that we had, the one that saved us 2/3 of what we were paying per month. Printer contract, which dropped us in half on that one. Now I'm looking at our big spend, which is Apex for managed services. That's due in March. I just created a draft RFP. I've been speaking with 4 or 5 different MSP companies on what Seneca needs now, not what it needed when we signed with Apex, because it needed Apex then. But what we need going further, dropping that, getting that operational cost down as much as we can. It shouldn't be news to Apex as we have our weekly ticket calls. It's gone from 30 calls to 2. So they know we're not utilizing them as much as we were.
Will this contract include assistance getting set up in a new
Yes,
building?
so well, those were all ad hoc
Yeah.
type projects with Apex anyways. So yeah, and that's why most of the companies I'm talking to now are healthcare focused. So Apex is a great company security wise. They got us all set up and everything. Understanding clinical workflow, not their strong suit. I need a company that understands that this is not my machine when I'm a clinician. I am using 20 machines through the day.
Yeah.
So, yeah, I have to have utilities and tools that are flexible to moving around. And then dealing with medical device equipment and being very black and white in security is great, but healthcare equipment sometimes is a little gray, and how do we get around the gray, keeping that equipment running? That's my big nut to be working on, that, you know, the RFP will be going out, the contract's up in April, trying to get that pared down. I don't know, Apex model isn't really hospital model, it's a small business Monday through Friday, no support on site, they take care of everything. So I don't know if they have a pricing model that will match us, so I'm hedging my bet and talking to as many folks as I can. The next thing we go through that, after that, is we are using Apex to start our SharePoint conversion. So that gets, gives us a little more redundancy as well, that if anything happens physically here, that stuff's in the cloud. But also will make sharing teams, groups, things way more productive, as a lot of staff work remote, increasing our security of those documents and that information, and also operational savings. So right now, all our office licenses are full licenses at $23 a month. 60% of them probably could be the $8 online web tool. So you have Word and Excel, but it's Word, Web, Excel for most of the clinical staff that are just looking at things. So that's my next step. Once we get into SharePoint, Microsoft has built it, so you have to be in SharePoint to use the web version of the tools. You can't access a local drive if you have those. So that's the other project for us this winter. Other projects we have budgeted for is moving MedWeb to the cloud. So PACS images are in the cloud, and much easier to share with other facilities. We just recently set up with Quincy and Renowned PowerShare, so sending stuff back and forth. But they had that issue with their CT went down, they sent the patient up to us and they needed those images. So that's kind of progress wheel right now, is looking at what we were spending and how do we reduce that expense. Yeah.
So is SharePoint gonna be like where all of the Seneca employees will access Seneca information,
Yeah, so our
Policy,
department drives,
procedures,
yes,
things like
yes,
that.
so that'll be, you don't have to VPN into the hospital, you don't need
Right,
special equipment,
yeah.
you can be on a Chromebook, you can be on an iPad, you can be on anything.
And it's
To do that.
secure.
Yeah.
Right.
Protected, so.
Right.
Yes, yes. So our big holdback was getting our internet strong enough to move all that stuff to the cloud. Because everybody accessing it through here through 100 meg circuit. And then trying to run center and trying to run imaging through that tiny straw just wasn't there. So like I said before, we got from 100 to a gig at 1/3 the cost too, so.
I think a big project for all the departments also.
It is.
Organizing their
So-
SharePoint site and
so
uploading all their.
What it is, it's also a time to clean up and protect. The incident I had at my last facility was a 12-year-old Medicare document, when Medicare was using social security numbers only as identifiers. So one file was a big problem, when it got out. So cleaning up those files that, when one department head takes over for another one, they just keep all this stuff. Nobody ever weeds through it and throws away the junk. This is the time to do all that analysis and get rid of that.
You have retention, is it 7 years?
So, yes, so there are things that we can, what I did at my last site is because of budget cycles and things like that, I use a 24-month, hasn't been tested 24 months when I'm looking at the files. If it hasn't been tested 24 months, that's a candidate for an archive. And get it out of live storage. I don't like really throwing it away, but putting it in a lock secure place, where we can get to it if we do need it, that's one thing, but if you haven't.
Chief archive instead of ice coming archive, yeah.
Well, and it's kind of locked in a vault. We know it's there, we know we can get to it, but it's not,
The document.
we will try to standardize.
She's a project manager.
Yes, it is,
That is tough.
Microsoft likes to take your Excel file or your, the first sentence.
Well, but it will help with versioning. It will help with version control. Right,
And
but it won't help with naming conventions, and that's just something that is so hard to get an organization to buy off on
Yeah,
and get compliance.
Yeah.
Tried that so many times in different facilities. Gosh, it's so hard.
no, it is, and the filter structure is probably place one to start.
Yeah, the older structure, yeah.
365 will have much more searchability than we currently have, and much faster searching for those documents, content in those documents, as opposed to just the
You
header.
have to get it exactly right.
Yeah. But yeah, it is, that is, we're in the discovery phase now, so we're gonna see how ugly things are.
I think it's gonna be kind of icky, but that's okay.
Yeah. But, the number one, no, absolutely, and that's what, Brady and I talked about, this is the kind of stage, that kind of stuff where people have a little breathing room and can think. They're not just trying to plow through it, and then like MedWeb clinical things, trying to get that through before we get our busy season. That should be an easier conversion because our archive's already with MedWeb, so it's just cutting over the live information as we'll do that.
Great, thank you, Brian.
Yeah.
Any other questions for Brian?
Nope.
Rich, do you have anything?
No, thank
Okay,
you.
thank you. All right, then let's move on to Shayna.
So, recruitment updates, this is a little outdated now because of the potential to have a week in-house supervisor. We were focusing on the DON administrative assistant, but with that potential employee coming on board, Judy and I have had some conversations about maybe removing that position, supplementing it with a week in-house soup and also a part-time director of staff development. So that's kind of the game plan for that, since we haven't had any applicants. If they do apply, they don't have the license. Yes. So we've been focusing on getting Charlene's team jabbed right now. We were able to fill one of the full-time positions. We have one still open, but I'm looking to make an offer to somebody, hopefully tomorrow. And then she has her two individual only.
Let me know this.
So, we're getting her to a level that I think is a little more comfortable than what she's been walking through. And then kind of following off of what Brady's done with his board report, I'm hoping my future goal is to add some statistics to what we talk about here. And my first idea was turnover. I don't know if you guys have any ideas of what you would like to see as far as recruitment or workforce.
Yeah, I mean, turnover has always been kind of our big one we watch, and that's the whole reason for our conditional ad, transfer deletion table. That is all so that we can kind of see what, yeah, we had requested HR add that like years ago because we kept hearing that people were leaving.
Yeah.
But we didn't really have a way of.
To see it.
But if you have a better way to present this, we'd be certainly open to.
Perfect.
to
Well, I'll put some stuff together and we can I'll bring it next time. The open positions, we have quite a handful of CNA openings. So a new focus is going to turn into the CNA, we get one, and we got some full-time positions over there.
Are we looking at doing a CNA program again?
So, yes, we didn't do it this past year because we were so fully staffed. We didn't have enough openings to do a fall.
Got it.
And so, but now the turnover has occurred, and so this year we'll probably look at doing another CNA class to see what we can get locally.
We have had some applicants, but they're not returning my calls, so. So additions that came through as a vendor, we had, like Judy said, the 2 per diem. We also had a registered nurse per diem that is on board. We have 4 people in the pipeline, so hopefully we can get them going for December. We did have some transfers. We had 2 full-time positions that is per diem, 1 medical assistant and an LVN. And then we had one of our CNAs go from part-time to full-time. Then as far as people leaving Seneca, Jenny obviously left in November. And then we have one from Charlene's team that we filled, and then a CNA full-time.
I think, as you're kind of wrapping around this, if you want to let us know if there's any additional tools that you don't have, what you feel like you need,
Okay.
let us know, because I don't know exactly what, I know we provided some tools, but I don't know exactly what they are.
I'm still in that learning process, you know,
Or, yeah.
picking everything up.
If you come across something and say, oh, I just really wish I had the ability to do this, and here's how I could do it, we certainly be open to hearing.
I think we're still really, at least I am, learning a lot about Paycom's capabilities, because we're actually using Paycom for our evaluations now, we're using it for our applicants. When it comes to the manager now, and we can look at it directly, and it's real time, and we're just still exploring all of the capabilities of Paycom.
And there's 2 tools in there that I'd like to work on is adding all of our licenses and certifications. And then also there's a tool for vaccinations. So it's all with them and Paycom. So that's a future project.
So then that will match, so as you apply, it'll tell you if they have.
I don't know exactly how it works. I just know it's out there. And right now we're tracking it on Excel.
Yeah.
So it'll be a lot easier to have it, and it'll send reminders to the employees when it's coming due. It'll send reminders to the managers when employees are coming due. So I think it'll be a lot easier, and we'll stay on top of it better.
So something to keep in mind, Judy, and I know you know this, that Plymouth District Hospital will be opening up their much larger scale this spring, so.
Who, did you say?
Plymouth District will be opening, so if we do a CNA class, we wanna be awareness of that they're gonna be really pushing hard for filling CNA positions, just wanna create some awareness about that, what could be a vacuum, we just wanna be
Do
careful.
they have a date, do you know?
Or that last one I saw was early May.
Are we getting any interest? We still have our CNA program on our website. Are we getting any interest on that?
So we haven't gotten in the past couple of months, but what we did. That we weren't very up Well, next year. So the beginning of the year, before we knew if we were doing it or not, we did have 74 that our website is information, but then once we send them more information, that's where it dropped off drastically as to what we're interested in. And that was this year,
And I believe
we made that decision.
PDH did a CNA program themselves, didn't they?
Yes.
So they're trying to grow within as well,
Was there
grow their own.
like,
With it is aid training, but then they get reimbursed through the Butte training. It's, so if we, you know, if we don't bring them all along, it's not a huge problem. Hope though is that we'll figure out which ones set it suitable.
Right, Seneca level, right, good.
so if we do that from the beginning, we push it out through the high school and college, like we did last year, and push it out that.
Good.
Thank you. Thanks for all your.
Thanks, Sean.
Thank you. Good job. Thank you. Okay, let's see now, Chelsea, you're up. Hello. Next year, going up next year, so we jumped into the all of the grant revenue stuff is is designed now for next year. So all of that we're working on, radio ads, what you want essentially is what we're working on. We're still continuing with our printed media that we do. We are always working to, if there's other options available. We are putting a little more into the news, that newspaper that's in Mulvey. We're getting feedback that people are actually starting to get out and read it, so they have pretty good stats for our area. So we're a little bit more into that, just that and we'll reach that and stuff like that. Again, they don't have Facebook, they don't have, that is still our different. The other one is Country Club newsletter, which is small things for here. Let's see, West Shore doing newsletter. So the West Shore doesn't do does updates or anything that we put out, shares it with social media and also email people, but they don't actually print it. And we still, other we're planning on being that schedule this year is the right schedule of where we're what community events, what places we're gonna have executive that, what board members at, those around, wait for the process, all of those things. I think it's we'll share them, all of that, so. You guys plan your schedule accordingly. We have press releases going out, so Stephanie can start, but her press release is not going out until January. To give her time to get on her feet and get her sorted out and out to the community stuff, so they can push them. We have Stephanie here that we're also going to push all of our other providers as well, and then we also have all of these providers. So you're there for the we don't, they're all touching. Trying to see. Is Stephanie doing walk-in right now? Okay, so Heather being as busy as she was Monday shouldn't happen like next Monday, because Stephanie's doing all the walk-ins.
Well, we do a rotation in the walk-in, but it also,
But she doesn't have a patient coming yet, that's why.
yeah, it's also depending on when they present and who's open too. So but yeah, Stephanie on Wednesday was doing walk-ins. Thursday, today she has her, and just word of mouth, she was pretty scheduled all week. So it's, but yeah.
Sorry. So we'll put out more information about Stephanie. We have all the signage, things like that going on. Meetings are going up across all the platforms, which is great.
I'll bring that forward. We are at, our new goal was at 4.5 now.
Ooh,
And it's, the reason is we are now we're reaching out to people immediately for positive, because people that don't have, people have good things to say tend to not,
It's usually
but get bad things to say, but reaching out, it's been very, what a shift. Jumped on us 4.5. Every single one.
We will get rid of a lot on that. There. So it's working, when we are getting all of the geo, planned out for this. So it is more expensive, so that targeting primary audience, or primary residents, or their residents. Them by their, area code. Well, I'm trying to remember. We met. Cell phone hit this location, we want a human for this, or when they hit this location, we want a human for this app. And so, but we can put demographics in, if you want to take cell phones that are people that are between the ages of 40 and 65, say between this age and this age. Now, the more detail we get with it, the more expensive we get. But in general, it's less expensive, it's basically for but we can be very selective is to open up people that have PhDs and have this and this and this, and you get to a targeted provider at. It costs more per thing.
Content too.
Don't forget a charging per fee. And then so the stats that I brought to you guys 2 months ago, that shows you what providers they were clicking on, but what the data that we don't have is one, and it also shows you which phone saw that and then compare. What I don't have is what providers we actually saw. So that's the, they then compare to the phone into my location.
Yeah, and it can get expensive, especially if you have like a sponsored ad. So they jump onto Instagram, YouTube, or whatever, and they're in our geofenced area. We can literally have, if we want to spend, we can have a sponsored ad about Seneca that they have to watch it before they can move on to their application. That's expensive. Oh, yeah. Yeah, you notice that?
How we target the people we're targeting, so like, we're not going to target people whose primary residence is
Is
here in
here.
Chattanooga.
Yeah, they do.
That's what I'm sharing those is if we're taking certain parameters for during the period where people coming from out of the area, how does it know it's people from out of the area versus people here? It's all the data. So you can actually exclude, you can actually exclude the residents, yes, you can look for more of like, this is their, it's phones that come to this area, but their resident is Chico or Red. But also on the reverse, July weekend, we hit phones that came to Main Street. So we selected like a bubble of Main Street, set and all that stuff. Right. Now, it's only going to be people that are open to certain apps, so they've got to be open to Facebook, Instagram. So it's going to hit those certain. But yeah.
I don't know.
It's scary.
It is scary.
And like store should be open around employees, and that is for employees or anybody that wants. Or, and then you just be right there. And so, you know, we'll start with the kind of logo stuff and then we can. Yes.
Yeah, so the geofencing I'm really excited about, and this addresses how Rich's question about how do we reach our summer visitors, our visitors, how do they know we're here? You know, obviously there's other mechanisms to do that, but every time they launch YouTube and they see a downtown Chester, like Elmore Community Hospital, whatever, at least it hits them. Now, I ignore that stuff and I'll wait for my thing to move on, but it's awareness,
Pretty
so.
cool.
Well, I think if people ignore it, it's still in the back of
But
the. If they need it, then there's that, and more likely, so statistics show that if someone has a senior level purchasing and then if they do feel something, they're more likely to run that location as, yeah, and I can go there, I've heard that. They might not know how to do it, but
very cool, cool stuff.
So the Grateful Patient campaign, so we have stuff going on the website, we are, starting to kind of promote more of the Grateful Patient testimonials that we get. We're trying to really follow those up with those people and then ask their permission to put them out to the public and post them. So, if you guys haven't looked at it, sure. Surgery. I'll leave you there. So there's some pretty good ones. We are, now that we're in the winter season, we're circling back to our leadership. So we got through some of them and now we're gonna pick that up again. We'll be going through more of the leadership. So we wanna just continue to do that year round. So we're gonna rotate through that, but obviously during certain seasons, they kind of, we rehearsed a couple here or there, because we were focusing on other things. And the get to know our providers, we are actually doing videos of the providers. And so each provider has different topics that relate to different healthcare days and things like that. So we're recording videos of them giving patients education tips, talking to them about those things. So like cardiac facility, want to be safety. And basically it's done in our clinic, just ask questions, do Q&A, and so we're putting that together, and then those are the things that we also get them familiar with our providers more, but also just other.
That's something that, sorry, go ahead.
I'm just asking. So like the storage for the videos or like for the people? Either. Okay, so they're gonna live several places, so they'll live on the website, they'll also live on YouTube. So YouTube, we have YouTube account, we'll store them on there. Right, so we'll link to them certain cases and scenarios, but they're also like that are under logs. We can add content to that, so there might be a time that we say, okay, it's July, we're adding safety awareness to the state providers to talk about as their. And they'll do that, they might be here for a long visit, but they do that.
That's an example of something that'd be really great too, at the beginning of our summer season, have one of our providers talk about, you know,
That's it.
what to watch for, be careful here, guys, and hey, if you find yourself in need, come see us.
Okay.
You know, it's just really, really, personalized a lot. Yeah, elevation, sickness. Good,
Okay, any other questions?
great stuff.
So then, the branding. package.
I have a suggestion, Jerry.
What,
Uh, I don't know if I'm the only one on Zoom that has difficulty hearing somebody who's not at the table. But, you know, I have a written report, so I didn't have a problem. But I can't really hear a presentation from somebody who's not at the table.
Okay, thank you, maybe,
We need to start
maybe
bringing,
next time.
we'll have them sit when they do the report, so.
Makes sense. You guys took all the feedback. You starting the logo. I don't know if she printed it out, but it's 32 pages, so yeah, it's a big package, but basically this is what we use for archives for branding, so it has. It has the fonts that we use, it has colors, all of that, but then I laid out all the logos that we use for the different applications, so that way you guys can see all of it.
Great, I don't know if you guys.
So yeah. That was next.
Work.
Administratively elegant.
And implies healthcare, right? Okay, so. Good help. Good job. Thank you, Justin. Okay, let's see, Charlene, she's got her report for close, so Steve, you're up.
Okay. Go to page 2, Brian, please. There you go. Okay, we're looking at the month and 3 months ended September 30, 2024. For the month of September, we had a loss of just under 377,000 versus a budgeted loss of just under 324,000. So a negative variance of 53,000, not bad. Year to date, loss of 787,000 versus a budgeted loss of 681, a negative variance of just under 106,000. So not bad at all. Looking at the, excuse me, looking at the month of September, our revenue continued to be positive to budget, but again, almost entirely from outpatient services, and also still generating a lot of positive revenue off of our wound care services. One thing is our deductions to revenue or our net revenue percentage was slightly, was 2.5% negative to budget, 68% net revenue percent versus a 70.5. This is primarily due to the aging of our AR and allowance we put on AR when it ages out. Good news is we filed our fiscal year 24 cost report last week, and our overall reimbursement percentage is going to go up over what we budgeted for 25. So we will easily, once that rate goes into effect, but that won't be until March when they settle the cost report and do a retroactive payment on our services from the beginning of the fiscal year through the date that they settle, or they true up, I guess, better. So between that and possible improvement in the AR aging, I think we'll be well above our reimbursement percent. So that's good news. Now, the other side of that is that a piece of our increased Medicare reimbursement was our outpatient reimbursement. And simply, our Medicare outpatient reimbursement is our cost of charge ratio. So our total costs, allowable costs for Medicare divided by our total revenue. And so for fiscal 24, even though we had a little bit of a bounce back in the spring and then into June, we've had a big increase in outpatient revenue going into the new fiscal year. So we anticipate that that's going to come down. But the inpatient is still down and consistent with what we had in 24. So that increased reimbursement, we'll see that into this year unless we have a big turnaround on our inpatient and swing volume. So what this all led to was we had a positive variance for the month in total operating revenue, and we also have a positive variance in total operating revenue for the year to date, 3 months. What offset and created the negative variance was our expenses. And there's 3 pieces of the expenses that are creating the negative variance. One is our salaries and wages of employed staff, negative variance on contract labor, registry staff that Judy Klein spoke about. And for the month of September and continuing into October, not as much. And then into November, again, not quite as much. It's trending down as we've eliminated the use of locum providers in our clinic here this past month.
we had a fairly significant variance in the month of September of 45,000, and that was due to adding 2 primary care physicians. Or employing or utilizing 2 primary care physicians under a locum basis at locum rates. The other piece is supplies, which is the cost associated with the wound care program that is supported by the increased revenue. Jumping back to our employed staff, couple things, we've taken a little bit of a deep dive, worked with Judy Klein quite a bit on this to look at why we're having our FTEs are above budget and our dollars are above budget, while contract labor is also above budget, not relationship we're looking for. Many things going on here. One of the things with the contract labor, as Judy mentioned, the majority of our registry staff is on extended or it's not they come and they go. They sign a 13-week contract or whatever it may be. And so even when we acquire the employed staff, we still have to honor those contracts, and sometimes we have an overlap there, and we're starting to see that overlap dissipate as we get in here into December. But within the salaries and wages, I think simply stated, I think I under budgeted a little bit in a couple ways. I thought we could manage our staffing a little more aggressively than we can. And the point there is 2 good examples are respiratory therapy and radiology. They work, the techs work 12-hour shifts. And so they work 3 12-hour shifts in their full week. So they have 36 hours of regular time, then they go on call, they get called back. So, you know, they're truly a full-time equivalent. Problem is that, you know, 7-day work weeks. So we have 9 days to have it when we have full-time people. And we just, in Chester, we're just never gonna have per diems. You know, maybe we are, but we're not gonna have per diems, not gonna have part-time. We just can't get people up here. To get people to come up here, we have to give them more or less full-time shifts. So I definitely under budgeted both of those departments. And that's the way it is. We'll just have to go forward with that and see what we can do about that. Long-term care, I kind of missed the mark on budgeting there. We're now doing the social services activities position 7 days a week. We didn't do that previously. And under budgeted the administrative side a little bit. We are over on LVNs, and that's kind of an overlap again of new people coming in and shadowing, training, a registry. So a little bit there is part of it. One of the other parts of our budget variances in 2024, California legislature mandated that employers have to give their employees 5 days of sick time. And so that's 5 days based upon your shift. So if you work normally an 8-hour shift, and that's 40 hours, 10-hour shift, 50 hours. The clinical people that work 12 hours, that's 60 hours. And the way that this sick time works is it's basically 5 days of PTO, because no questions asked, no penalties for the utilization of it. They call in sick, you know, we have an MOU that says you have to call in so many hours before your shift, or you get incurrence points. If you utilize this sick time, it doesn't apply. So it's really an enhanced employee benefit, so good for the employees, but it kind of messes up the budget. It also messes up staffing, because when people call off, we have to find coverage, and we're not exactly, as they say, we don't have a deep bench. So in addition to this sick time, we also have kin care. Because previously you had to provide a certain amount of total sick time, half of which could be designated as kin care. And so we provide 24 hours of kin care So now we're providing 5 days of sick time plus 24 hours of kin care. So now we're looking at basically 8 days. And so Shanna and I have been talking, and we're going to look at what is our requirement? What do we need to provide in, time off benefits to the employees? And, are we right now a little heavy with what we're providing? And so we're gonna look at that. But right now, we're seeing high utilization of sick, we're seeing high utilization of kin care. And these are items where, at least the way it is currently, these aren't items where the employees can take unused time. They don't carry over from year to year. The sick time can carry over from year to year, depending on how you structure it. But it's our first year, so we'll structure it where it's not a carryover, because that creates a potential liability for the organization. So we don't treat it like PTO, where we budget for it, we account for it on our books, we account for the expense, we adjust to the expense. This is one where we just have to make a guess, because it's kind of off the books. It says they use it, we incur it, so that's something we're struggling with. So we'll be looking at that. Shanna and I will be talking about that as we go into the new year, couple weeks. So that's really what's going on there right now. Again, it's not, we're having a pretty good start to the year. Right now, our year-to-date operating margin and loss is 17.4% versus a budget of 15%. That's well below what we've historically run. So that's very positive. Obviously, it's 3 months when we had, summer and higher population, but we consider the seasonal effect of revenue when we do the budget. So staying close to that budget of 15% is good. As you can see, when we look at the month of September, the budget was 21.9. So we're already seeing that seasonal adjustment to revenue. So,
I don't know, 1 second. Going back to, when we're talking about how we have to staff based on hours in a week. If we have extra employee hours, how are we allocating that employee, I guess? So if we have double coverage, like 2 days a week, it sounds like?
some days we do, there's 2 people in the department, absolutely.
And so what are we doing to give them something to do, I guess? My question.
So for one of the departments we talked about is there's always work to be done. It just may be in somebody else's department, and where a department had staffing issues, that function, like scheduling, is a direct correlation to the workload that a department like radiology has. So you don't have the staff member to do the scheduling, you move the scheduling over to the staff members that have the additional time. And so in radiology, that was one of the things to try to make sure, that flywheel continues to go. And move that workload where you have that capacity. Now, the whole hope is they're so busy actually performing, everything gets going.
That we need to.
Yeah, and then when you look at, the radiology as an example, those numbers, that should continue up. So there's always plenty of work to be done.
Yeah, that's.
You just have to shift it to who has the available time. And then you have to cross-train.
We have to know how.
Yeah.
That is.
That's why, like, in the clinic, we're cross-training everybody. Sharpton's group is cross-training everybody so that we can flex as, the season goes or flu season hits us. And, yeah.
I just wanna make sure we're utilizing them.
Oh, yeah.
I cannot even board if you don't have anything to do for a whole day.
Yeah.
Sorry, Steve, go ahead.
No, and to expand on that is, the other piece of that is that the clinical departments are now getting involved in Cerner from not just the patient care side, but they're coming involved from the financial side. Where they're going to be reviewing their charges, correcting their errors. And it's a big thing. It's going to involve a dedicated effort on their part, which we haven't had so far, so.
You mean providers? The provider?
No, the techs,
Oh,
yeah.
So they have onus.
Right,
Awareness of what's getting missed, they have onus, and they hopefully get to a self-correction. Where they see the trends. You know, this is all part of creating each individual department as its own business. They have awareness about how much they're spending, how much they're wasting, how much stuff they're throwing over the fence to finance, to fix. That's all a part of that accountability, department accountability. And then we're gonna get into, then we'll get into, you know, FTEs to RVUs some 20 years from now. Which, you know, we're used to seeing, you know, you have X FTEs and how many RVUs you put together and they don't equate. Why do you have people sitting around? I mean, that question is asked every week where I was from. What are they doing?
To Steve's point, you know, if we had the low census, you know, LC employees like we do down the valley, we would never have a workforce here. You know, we can't call off nurses because we have no patients because they need a paycheck.
right.
So we would never protect our current workforce if we were to try and cut,
Yeah.
you know, our losses in that way. We would end up so far behind.
Yeah.
It would,
Yeah.
it would be more expensive.
Yeah.
Cutting off your nose to spite your face. for
Yeah,
sure.
yeah.
Yeah, and we have made a
It's unique.
decision to, like, we have a new grad, okay, he's been on orientation for 6 months to get, you know, he'll be up. And it's a couple of weeks, but we made a commitment to, you know, okay, we'll take this new grad, only one at a time. But that means we're gonna be double staffed during those shifts when he's working. Well, we're trained that we feel like it's a long-term investment in our workforce again, so it's just, it costs sometimes to create your workforce that.
Yeah. There's a uniqueness to not having a deep bench and people who want to just coming through the walls to work for you. You know, it's a uniqueness.
And in the interest of time, I'll kind of just fold in revenue cycle into this discussion since we're kind of there right now. So, two things have been affecting our effectiveness of revenue cycle and our performance. You know, whether the measure is AR aging, AR days, whatever it might be. One was maybe the build of CERN was flawed, and we made monumental strides to get through that. And one of the places where that's gonna show, not in necessarily these numbers, but what we saw this week is that the discharge not final billed number, which means patient's been seen, the patient's been discharged from the facility, but we haven't sent the claim to the insurance company or tried to send the claim to the insurance company. And when you look in the stuff from R1, our discharge not final bill 4 months ago was $1.4 million. It started going down a little bit. In this report for October, it was just under $900,000. Yesterday, it was $606,000. So that's indicative of the system being fixed and the system working. There's still some things that are being held up that we need to work with, but the majority of it is that we just couldn't get it out of it. There was any number of issues with the claim, and you see that in the clean claims percentage and so we've kind of overcome that now. But the other piece of that affects AR is the claims that we've sent out that they have a problem. They've been returned to provider from Medicare or whatever it may be, they're just outright denied. And R1 will take that claim, send it back to us and put it in a lovely little place called Client Assist. And that's the part where, because of the way that we've been doing revenue cycle whereby it flows over from their clinic or whatever, and then it ends up in Cody, and they look at it and they try and work with it, and then they find errors, they send it back and say, I need this, I need that, I can fix this, but can you fix that? And we've continually done that. But the stuff that is coming back from R1 is going into these work queues buckets, and they've just been sitting there. And we haven't got, if you look at there, you can see the aging of it. We did talk to R1 about this, and the aging is based upon the discharge date, so it's not necessarily indicative of how long it's been sitting with Seneca staff and how long they've had it to do something with. It's how long from the date that patient visited here to, we still have issues that's addressing or resolving. So we started with our own revenue cycle team. The big area was in registration, to have registration both in from the hospital side and over here in the clinic. Look at these registration authorization type issues that we're hitting, and to have them start working this, because there's hundreds of thousands of dollars in there. Then we also have items that are sitting in there waiting for information from physicians, clinical staff, whatever it may be, to put that in there. So not next Tuesday, but the Tuesday after, it's normally our department managers meeting, and we're not having it this month. So what we're gonna do is we're gonna bring all the managers in and from the clinical departments, and we're gonna kick off showing them how this works and what they need to be doing, because we kind of led them to it, and you just, that didn't work. So now we're gonna sit down and get knee deep in it and say, here we go. And so to your point about what did the departments do? This is what they'll be doing, a big integral part of what they do within their job, and pay big dividends. So.
I don't understand it, the meaning behind it.
It would work.
Yeah.
Exactly.
That's great.
So that kind of covered revenue cycle. It's kind of unfair to send you guys an October report, but at least it's better than the past few months, but it's still a ways off to where we are right now, so. Okay, so questions about financials? Ask question about.
I'll make a motion to accept the financial report for September.
I move to accept the financial report.
Do I have a second? Thank you, all in favor? Rich,
Aye.
Sherry, Michelle, and I'll vote aye.
Good job, Steve.
Thank you. And when I was going through my report in September, I realized I left out a couple pages I normally put in there. The analysis of the provider expense and the outpatient revenue, so I'll get that to Deborah and she can send that out to you. I also have another document from another part of something that was created after the packet went out, and I'll get that to you. So cash flow report, real quick. Needs to be. Okay, the big thing, obviously, with the cash flow report is that we received the line of credit on November 22nd. $1.5 million. We paid out a little over 40,000 earnings to Western Alliance Bank, so we netted a little over 750. We went ahead and paid a bunch of payables and are keeping our vendors at about 45 days, with the exception of properties we rent, local vendors. And now here in December, I've got 700,000 in there, but we're planning right now to draw 400 and just leave a little bit extra for January. And
Can we draw that at any point in time?
yes, I mean, it's literally just a form I send in. I said, send us X dollars, but again, we've already drawn 800. We're gonna draw 400 next week. And then that would leave 300 left. One thing that changed from this, which actually was quite helpful to us, down below, we were supposed to do our HQAF intergovernmental, let me back up. So in November, before we received the line of credit, we did do our rate range intergovernmental transfer, so that's the big one. Now, it's projected that we'll get the rate range supplemental payment of just over $6 million in February. Upon submission of the IGT to the state, I contacted both California Health and Wellness and Anthem, the two plans for at least this year, calendar 23, that requesting a advance or expedited payment of the supplemental funds. Last year, California Health and Wellness came through with some funds. This year, they responded and they said, we'll do what we can. I believe them. So we're anticipating that we'll receive possibly some or a big chunk of the amount from California Health and Wellness, which is 60%, a little over 60% of the total payment. Anthem's the 40%. That we could see that by the end of the calendar year or early January. Didn't hear anything from Anthem and don't expect to hear anything from them. So that's taken care of and the ball's rolling on the advance payment. But the HQAF, we were just notified that 323,000, that it's the last year of HQAF. So I guess the state's trying to really reconcile things before they do the program, and they've actually deferred that IGT to March of 2025, which is really a big push out. But what's nice about it is then that means that we anticipate that we'll get our supplemental payment in May or June. And it just creates a nice flow where we're gonna get supplemental payments each month, you know, after the rate range payment. In addition, we'll receive probably about $1.5 million in March from our cost report settlement and the true up. So that's all projecting out well. We just need to get through the next couple months or this month and January. So I don't have large concern about that, but it's just hang in there. Any questions about the cash flow?
So we'll be down to 300 in our line of credit.
Instead of drawing all of it.
Yeah.
After,
Just in case for January.
Mhm.
Yeah, after drawing next week. Oh, you know what I did mention about, one thing about the revenue cycle is we got a rhythm going with partnership now. They're paying us in the subsequent month, so they're paying us within 30 days. We're getting, yeah, it's very good. We're getting our claims in first of the second day of the month, and then they're paying by the end of the month. They did that in October, they did it in November, so hopefully December is.
Is that a special request or is that just what they're?
Getting the rhythm down.
Awesome.
They've done, the claims are all getting accepted and, you know, they're clean, there's no problems with it, so. And we had a little change in the makeup of the census recently. But we were full partnership in November. And then we've taken on some new residents and I think they'll ultimately be partnership, but they, you know, have to get their Medicare, Medi-Cal established, and so. That's it. I think that's it.
What, 90% of our long-term residents are partnership?
I think we have two. One came from a county that was not a partnership county, and one is new to Medi-Cal, and apparently when they go into long-term care, they're in straight Medi-Cal for some period of time. And then we have one other individual that's still.
About 90 days, like 90 days intern period or something like that.
That's pretty close. That seems right.
So do we just absorb those costs or how?
They go retro,
Say what?
they go retro.
Okay.
So they'll go back as soon as they're approved. They'll go back to the date of admission as long as it's not beyond a certain period of time, which it never is.
Temporarily is.
Right.
But yeah, you're here for a short period of time. Okay, I think that's it for cash flow.
Also,
Yeah, I don't know why we put it up there, but it's probably not a bad idea.
Should there be a cash flow report?
thank you. Sherry? I, Rich?
Aye.
Yes. Okay, now, thank you.
Okay. Revenue cycles, I just don't really want to get at it, really the high points for those two things. If you guys have any questions about that, shout to me. Hit project funds, would you please, Brian? Okay, so just rotate this, and I'm going to just say, this is something that we have decided to provide to you guys each month. And it's just a summary of financing activity. The two pieces are the loan draws and then the project expenditures. And then we retain a certain balance of funds with Western Alliance Bank. We haven't spent anything out, so like, and I did it through November. So at the end of November, we had done loan draws of $9,385,656. And we had cash with Western Alliance Bank of $6,662.79. Excuse me. And the subsequent, just go through it just kind of slowly, Brian, and so then this is just a detail of the accounts. We have two separate accounts, the certificate of participation fund, and that has two pieces to it. It has actual project fund, where it's under the project total. Those are funds that are available to spend on the project. And then the other one is we have a funded interest account where we have to pre-fund our interest that we estimate during the construction period, including the 5,000 we put up front. So the 3,013,964.38 under the project total is available to spend on the project, mainly for stuff that's Montley Hammond, the contractor, and equipment. It's for the administrative stuff. And Brian, can we just go to the next slide? And this is just the activity within, just shows the individual account. This one is the project fund. It just shows where money went in, money went out, and then it gets to the ending balance. We've done 2 pay requests with the USDA. There's pay request 2 and pay request 3. But 1A and 1B was the owner's contribution, 1B was the cost of issuance settlement. So this just shows that how we get to the loan draws and then how we spent the money. So the next one, Brian. And then these next 2 are the funded interest. So you just go to the next one. That first one had the initial 500,000, and then they just look at the 2 of them different. There's two ways they look at their interest. So they make us split the monthly payment. And then the next one. Okay, so here's the Geo notes account. And this is where we've been drawing most of the funds, the loan draws from, and been using it to pay, as you can see, the project payments. 2 payments of just over $2 million. Again, Montley Hammond and equipment. that's the end, so. If you guys have any questions about this, I'm just gonna do this each month. And, if you want me to present it any way differently, or whatever your pleasure is.
So, board members, did this make sense to you guys? Did you understand it?
No, I think it's nice to see.
Good, clear.
Yeah.
Rich, do you have any
That was
comments on
fine.
it?
No, I don't.
And so
I think you did a really good job putting this together, see.
Thank you.
It's very clear.
I appreciate that. So going back to the page one there, the $6 million that we hold with Western Alliance Bank. They control that money. Western Alliance Bank does. What we do is we make requests of them through the other two documents that I provided to you guys, which is the actual USDA outlay request form. And then they transfer the money to us and we pay the bills. So that money there is sitting with Western Alliance Bank. We can't do anything with it, but they did give us the opportunity to participate in an investment program that they have. They have like a sweep account. And I'll send this document to you. We got our November interest after this went up. So we're able to earn about 3.5% interest on that money. So that's a pretty good deal. If we had the money ourselves, we could stick it in lay for buy treasuries and get a little over 4, but 3.5 and not have to do anything with it is just fine, I think, for now. The COP, we're paying 5.25% interest on any outstanding balance, so. And the COPs are a little less, 5.1, something like that, so. That'll help. Okay. And I think that's it. The USDA draw forms are in there. The nice part about that one is it shows our project budget, it shows what we spent to date, and shows how much we have left. You can just pull one up from Briner, they're both the same and just have different numbers in it.
Did this make sense to you all as well?
So that second column in from the left, revised budget is our total project budget. If you look down row M, total cumulative cost, 83,700,000. That's our total project budget, including up there, row E, interim financing interest, construction period interest. And that's only on the COP because the GO bond's kind of off the books. As far as that goes, it's just paid with the, assessed taxes. Okay. That's it for that, unless there's questions and you guys want to just.
I think this is perfect, so you'll bring
Yep.
whatever is available every month if we don't have it out.
Whatever is doing. So real fast, I have a item here.
Number 8.
Right there. Okay, so as you guys recall, the discussion about rate range and the intergovernmental transfer, and we received the enhanced supplemental payment through increasing our rate range, and that was done by this organization, SCA Consulting, working with the managed care payers to increase our rate, increase our IGT and in turn the supplemental payment. We agreed to pay them 15% of the net benefit, so supplemental payment plus the IGT year over year from 23 to 24. And it looks like we'll be paying them about 200,000, we'll get the 6 million in January, February, whenever. They think there's an opportunity for us to continue enhancing our rate range program, especially now that we're a partnership. Very good thing is that these gentlemen said when they meet with their partnership has been up here multiple times. They met with clinical, they met with quality, They met, the financial and operational people came, and then some, revenue cycle people came, business services. And they all had the same impression of Seneca. They like what we're doing here. They really dig that, back there. So, they want to do anything they can to help us. So that's it. It's a good on all of us. So what this proposal here is just to extend the agreement we had with them to one more year. And so what'll happen is the supplemental payment we receive here in the next month or so will be the base for next year. And I know it says calendar year 23, calendar year 24, these things run 1 year behind or 2 years behind, actually. That, right now, we're settling calendar year 23. Possibility that when they do calendar year 24, with first year with partnership, that they'll squeeze it into the end of 25 and we'll get closer to being, not 2 years behind. So whatever we're getting now will be the base, and if they don't get any more than that, then there's no compensation to them. If they get more than that, then they get their 15%, so.
It's fair to me, for the motion to approve amendment number 1. SCA rate range consultant contract.
I moves.
Thank you, do I have a second?
And second.
Thank you, all in favor, Shelley?
Aye.
Carrie? Rich?
Aye.
Thank you.
Yep. That's it for me.
Thank you so
All
much.
right, so Chelsea, it's you for the Healthcare Foundation report. Hey. So.
Any questions before I jump in? Okay, so as you all heard, we officially have a 501(c)(3), so we've launched that. We are taking donations directly now, which is great. And Blackbot, our donor software, is up and running, so it's running and we are working out all the kinks with the software launch, but
Huge undertaking, thank you.
it's a lot, it's a
Too bad they
whole.
wouldn't let you do any of that tweaking before you.
Right. Right, they wouldn't let us do it before, now they're letting us do all of it, so we're getting everything implemented in it. What'll be nice is once this is fully up and running, like when a donor donates, then we can set parameters of, if they donate between this much and this much, we get this thank you letter. Then at this level, they get this thank you letter. And it will automate things, so it starts a workflow process, so as that donation hits, then it sends Brandy an email, says, you need to mail this person a letter, it sends me an email saying you need to call this person, or whatever is going on.
To fill all that in initially.
And that's what we're building right now, is we're building all of those workflow processes right now, so that way, when those things do come in the future, it'll like initiate all of that, whereas right now, we're also still getting donations, so we're building the processes, and then we're also making the phone calls, sending out the thank you letters, all of that. And so it's going good. It's just busy right now with the foundation. And this is the time of year that everybody's got the tax questions, the year-end giving. And so it's a great thing. And we're just trying to keep up with it. Donation acceptance, like I said, we're accepting donations. We are getting the occasional check that is written out to the district. We're just working with Steve on those. So far, those have just been deposited directly to the district, but we are going to work out a process for how we're going to accept those in the future. And then, it's a little confusing for donors right now because that initial letter that we sent, we wanted them to donate to the district because we weren't sure who could have that 501(c)(3) standing. So we definitely don't want to go back to donors and be like, can you rewrite this check? So we are working that out, and then we are really pushing for next year with all of the information that goes out to make checks payable here. But I still think it's gonna happen in the future. People, they're gonna be used to it, or they didn't pay attention, and so we do just need to have a policy of how we can handle that. Other than that, grant application, so most of the people that asked us to fill out grants have already allotted their grants for this year, so they have said, fill it out for next year. So our applications are ready to go. We're just gonna wait for the parameters to come out for next year, and we're gonna submit those grants. So
We've talked to Collins, FPI,
PG.
PG&E, and then the KBK Foundation. So those are all ones that had initially said, yes, we want to talk to you about some grant opportunities. So all of those are we're still tracking those, they're still ready to go. Other than that, we're working on budget for next year as well, working on the golf tournament, which we've attached the draft packet. So the packet's not finalized, the sponsor letter. The sponsor letter and the sponsor opportunities is what will go out first. And so like Brady, we personalized it, a version for Brady, because he's gonna work with some of his people. We'll personalize a version for Sean and a version for Judy, so that whoever's reaching out to them can go and connect with them. The save the date sheet is something that will go up next, and that will have all the sponsor information, and then the player registration form, we haven't really touched that much at all. That's just a general, we threw some stuff in there, but we will, to release, registration, that'll be towards in the spring, closer to when the golf tournament is gonna happen.
Our date is reserved.
The date is reserved, we've been meeting with Ronnie, we've already ordered our giveaway prizes. So we have a Bluetooth speaker, which people are really excited about the prize. So everybody I've talked to, they want to go golf just for that prize. So it's great. We just need some sponsors so we can afford the prize. And then, donor recognition. So, at the time of this report, we had a little over 69,000 in donations this year so far. And that was like cash and check. And then we have a little over 10,000 with net PayPal, so that there's fees and stuff that come out of that for PayPal donations. PayPal will be phasing out, and Blackbaud will have its own, and the fees are much less. It's a much better system for donors to work with. It tracks exactly which fund they want to donate, all of that. So we are transitioning that. The website has all the Blackbaud links in it. So we'll take it to better. Other than that, the employee giving is ready to go, so that will be launching next year. And we're working on the, information to the. And then will that be free? Or free, yeah, not
No, not
free. So it's post tax.
Yeah, it's deductible on your individual taxes or business or whatever, but,
Yeah.
um,
So,
They got bottom.
Mhm.
yes. It'll be, yes, and then it's up to them to go and an employee wants to, then that is. To file that. And, it did look up all the paperwork that they need, so employees do need help with that.
Yes, and could we provide, this foundation provide donors with, a sort of tax form?
So what the foundation, I'm working on the donation form. So basically the donation form is going to have how, it's going to explain to employees how they can enroll it. And then basically also it's going to have a legal statement in it that says, I understand that I'm signing up to do this. And then I have to be enrolled, So it has all that information. Then also with that, it's going to explain to employees, this is, this donation can be tax deductible. You will need to file it with your, whether it's your business or your personal taxes, however you're going to file it, and work with your accountant. But this is the IRS form that people typically use to do this. So there is an actual employee deduction IRS form that people can file.
Okay.
So,
I had somebody ask me if we're gonna get to the point where they can just go to the website and then, because a lot of the people use their airline credit cards or their Amazon or whatever, can they just put that in?
yes,
And-
so we actually, that is what's live on our website now. So when they do donate now, they can actually do credit card donations, they can do all different types of donations. The things that are not live yet with Blackbaud is like if they want to do qualified charitable distribution, that we still have to work with them on. So there's like 401k, things like that. A lot of that, we have to work with like Edward Jones or with Fidelity on that stuff. So it just depends on those ones,
Okay.
And they can give us Bitcoin if they want.
Yeah. But credit cards.
Just one.
take, And then one of the
Surplus.
things that we're working on is matching. So we're trying to get stuff launched on the website for people.
so they can better understand matching. So there's a lot of people out there, if they retire from a company like Chevron, they still match giving for their. There's, companies that if people currently work for them, they do matching. So every company has, different, well, not everyone, the ones that do matching have different policies and that they'll match. So we're trying to get information added to our website where they can just look up, here's my company, will they match my donation? So that should be another one that's fun.
Yeah.
So sorry about that.
Great.
Excited.
Thank you, Jessica. Thank you.
Looks like Donna's on.
So next is Donna on for the, item number 10, new physical access to hospitals, buildings and facilities. Donna, are you there?
I am here. I'm sorry.
We just moved on to you.
Okay. I actually had to moved my phone, so I'm taking it from my car now, and I would propose taking any questions that you may have on the report that was provided.
I read through the report as well as the mitigation, well, I guess we're just talking about the report right here. Board members, any questions or not on the report? No, I think we covered a lot of stuff earlier with Sean. Rich, do you have any questions for Donna on her report?
No, I don't.
All right, so Donna, if you want, we can skip number 11 for the moment until you're in a better place to talk about the next.
I think that I can do that one. I'm not gonna, unless there's a direct referral to the document. I can explain what this is and the intended reporting to the board, the frequency of the reporting to the board and intention of reporting to the board for this. So go ahead and proceed. Is that okay?
Yes, thank you. This was housekeeping. We're on item number 11 now. CEQA NEPA mitigation monitoring and reporting program. Go ahead, Donna.
Yes. So as the Seneca Healthcare District is the lead agency for the CEQA NEPA process, we want to make sure that we're updating the board for how we are working to maintain compliance with those environmental requirements that were determined through the CEQA NEPA process. So this is the mitigation reporting program, mitigation management reporting program that was developed through that CEQA NEPA process. We are tracking what you'll see through the different columns. We're tracking who's responsible, what the trigger is, how we're addressing it, how we're complying. And our intent is to provide you with that update on a quarterly basis. We are also providing it to Plumas County, to Tracy Ferguson at Plumas County Planning, and just want to make sure that you guys have the opportunity to see how we are complying and if there are any questions as to the approach of doing so.
Sounds good to me. Tracy's okay with just having it quarterly?
Yes, so we would provide this updated report quarterly. There is backup documentation that's referenced there. I think we just have to feel out how much information you'd like me to provide to the board. If you want all the backup, or if you just want the overall report moving forward. And if you want more, I can absolutely do that on the next go around.
Board members, any opinions on it?
I'd say we don't really need the backup unless there's something that's unusual.
Yeah, I think the executive summary that you put together here is perfect, Donna, unless there's something specific that you should be aware of, then perhaps at that point, whatever supporting document.
Yeah, the mitigation.
It's a good format.
Yeah.
I think this is great.
Alrighty, sounds
Thank you,
good.
Donna.
Thank you very much.
Thank you.
Thank you, Donna.
So I guess that brings us to item number 12, policies and procedures. Listed ones we are modifying. Does anyone have any questions and comments on these? Okay, hearing none, I will accept a motion to approve the policies and procedures as presented.
I motion to approve.
You all in favor, Rich,
Aye.
Sherry, Shelley?
Aye.
And I'll vote aye. So that brings us to the medical staff report. Requesting approval for medical staff appointments that were approved at the med staff meeting on November 12th. Do I have a motion to approve?
I just got a real quick question. I'm wondering why Dr. Mark Nielsen is only being 60 days instead of like a year or something, or he.
Do I have a second? Thank you. Thank you, Shelley. Sherry? Rich?
Aye.
And I'll vote aye. Questions to our closed session, we're going to meet in closed session. Litigation, anticipated litigation, significant exposure litigation, concept for legal counsel, anticipated litigation pursuant to government code section. Also,
It's closed.
pending litigation, legal counsel, existing with. Like 6.91. Bellato versus Seneca Healthcare District, the case number is in the agenda. Health and Safety Code, section 32106, report involving state secrets. Also, public employee evaluation, closed session pursuant to government code, section 54957, public employee. Sure.
Yep.
Labor negotiations pursuant to government code, section 54957.6, conference with labor negotiators, agency designated representative, board chair, underrepresented employee, chief executive officer, and closed session compliance, government code 37624.3, health and safety code 1461 and 32155 periods. Subject matter report, quality assurance committee, presented by Charlene. I suggest we take it first and. All right, we are back in open session. During closed session, we had a vote. There was a motion made by Rich and a second made by Sherry. All in favor, Rich, Shelley, Sherry, and myself. And the statement is, the Bolt Company has agreed to resolve its dispute with the district regarding the replacement critical access hospital project in exchange for a mutual release of claims as further set forth in a settlement agreement that was now approved by the board of directors, such approval being made expressly subject to the concurrence, if required, by the United States Department of Agriculture, which is funding the project, of the USDA, and the execution of said instrument thereafter by the district chief executive officer, and that no such agreement shall be in effect unless and until such conditions are satisfied. A copy of the settlement agreement is available for public inspection, and the general terms of the same are that Bolt is agreeing to forego its claims against the district for additional compensation, but the district has declined to pay to date in exchange for the district's agreement to a reciprocal waiver of its own claims. And with that, we have our future board meeting topics, which we probably should review at some point, see if we can take them off and move them on. And our next regular meeting is actually gonna happen in January because of the holidays. And it's January 9th at 3 p.m. here in the conference room, and our meeting is adjourned.
Thank you.
Good, yeah.
It's right through that.
Yep.
Have a Merry Christmas.
Oh, Merry Christmas, Rich.
Right.